Okay. So thank you for Karen's kind introduction. I'm Dr. Carl Cheng, based in Taipei. So I want to thank Canada to invite me to present the picosecond technology and experience. So I hope you guys were healthy and confident in defeat the virus in the near future. Okay, so even in such a hard time, we still need to be very promising and positive thinking. So tonight I will talk about some uh, issues about the picosecond lasers. So I will talk over the topic of why pulse duration matters, especially in the picosecond lasers market. Okay, so laser-induced breakdown is a nonlinear absorption process to lead to plasma formations when the irradiation thresholds for breakdown is surpassed. Especially in recent years, the plasma-mediated procedures is used in various fields of laser medicine, such as ablation, photo disruptions, or lethal trypsin. And laser-induced breakdown can be achieved through different pathways. It can be achieved through the multi-photon absorptions, which we call laser-induced optic breakdown, or it can through the thermal initiation pathways, we call laser-induced thermal breakdown. Or sometimes it can be achieved through the photothermal emissions with laser or hot electrons of the surface of the nanoparticles. And laser-induced breakdown can induce breakage of the molecules and atoms bounds to accompanied by the luminescence, shock waves, and the formation of bubbling cavitations. And however, the irradiation thresholds for breakdowns to form the plasma is proportional to the pulse duration. So that means the longer pulse duration, usually the irradiation threshold is much higher. On the other hand, when we apply the very short pulse durations webbands, such as 200 to 300 picosecond, we only need very low energy to achieve laser-induced breakdown. So given equal energies for a nanosecond or picosecond pulses, you can see no matter in different energies or different pulse duration, you can see the picosecond pulse usually produce longer plasma formations. However, when there are laser-induced breakdowns threshold is surpasses, the nanosecond pulse usually can produce more aggressive photomechanical and photo disruption. So here you can see a higher surgical precision can be achieved with a picosecond pulse than with nanosecond pulses, because picosecond pulse have a lower energy threshold for optic breakdown, and the size of picosecond plasma near the threshold is smaller than that of the nanosecond plasmas. So picosecond pulse is more suitable for the very precise cutting procedure with little disruptions. On the other hand, the nanosecond pulses can be used better for the procedure needed more stronger mechanical actions. So PMI is a very important index to value for the mechanical effect. Only when the value is over 1, the pure photomechanical effect can be achieved. And look at the PMI. PMI is proportional to the fluence and inversely proportional to the pulse duration and particle size. So that means we need to use a very high peak power and with to treat the very small particle with very short pulse duration can achieve the maximal PMI index. So this article, they compare picosecond and nanosecond to see the disruption performance of tattoo of both picosecond and nanosecond lasers. And they conclude in picosecond laser, only half of energy can achieve similar disruption result of nanosecond lasers for tattoo removal. So laser tissue duration can be determined by the combination of power intensity and path duration. Here you can see the longer path duration, the more photothermal effect, and the shorter path duration, the more photomechanical effect. And when one pathway was decided, the energy will determine which stage you are arrived at. So laser-induced optic breakdown can occur when the laser intensity is really high to strip the electron from the tissues and to generate the plasma and expand the plasma and finally to form the cavitation bubbling. So there are 4 continuous processes for the mechanical effect. You can see plasma formation, shock wave generation, and cavitation, and even jet formation for the solid tissues. And radiation threshold to create breakdown can be determined by a laser beam characteristic, such as wavelength, path duration, energy, or medium characteristic, such as absorption and ionization. And the initiation with laser-induced breakdown can be achieved through 2 different pathways. As we mentioned previously, LIOB and ITB. And when the absorption coefficient is really low, the LIOB can occur through the multi-photon absorption with relatively high energies. However, on the other hand, when the absorption coefficient is really high, LITB, laser-induced thermal breakdown, may occur through a thermal emission with relatively low energy. So that means when we induce a breakdown through the LITB, we can use less energy to achieve the breakdown procedures. So take a medium, for example, you can see if we apply 532 wavelength, you can see the LITB irradiation can be really low. However, if we pick up 1064 here, you can see the LITB irradiation threshold is really high. It's quite similar to the irradiation threshold for LIOB. So what is the optimal absorption coefficient for lower irradiation threshold? According to the publication, it was between 10 to 250 centimeter to the power of -1. So take a medium, for example, you can see 532, 730, 785, 755, and 1064 were all optimal to lower irradiation threshold. So historically, you can see this slide demonstrate the so-called LITB pathway. You can see in the upper epidermis, the chromophore is less dense, so we need higher energy to induce laser-induced breakdown. However, in the lower epidermis area here, the chromophore is more dense, so we only need lower energy to achieve laser-induced breakdown. So there's another concept, so-called laser-induced cavitations, that when the absorption coefficient is not really high, and we need to use very high energy to cause laser-induced breakdown. And however, when we apply the median energies, we can skip the energy of the laser to the dermis to create the breakdown in the dermis. So this is what we call LIC, laser-induced cavitations. So when we induce a breakdown through the LITB process, the chromophore density and the energy is quite important. So this article, they compare the 532 1064 wavelengths with nano or picosecond pulse in pigmented micropic skin. Here you can see no matter in 532 or 1064 nano or pico flat top or micro lens array, they are all induced cavitations not only in the epidermis but the dermis. That means the density of chromophore is a very important role. So see how our case, this case was done by 532 0.3 millijoule with 3 to 4 passes. You can see it shows some cavitation vacuole in the epidermis. However, in melasma cases, with a higher melanin density, we just only need to use 0.2 with 2 to 3 passes with 532 fractional pico can induce such a cavitation in the epidermis. However, if we use high energy with more passes, here you can see we use 532 1.5 3 to 4 passes. It shows ballooning cells here. So that means the energy is really high to cause some thermal effect. This so-called LIC was done by my colleague, Dr. Harrison from Australia. He used a tensor 4 fraction pico to create LIC. So the mechanism of dermal collagen remodeling is still unclear. And with high energy, the epidermal LIV can be achieved through the cytokine mediations or shockwave injury. With medium high energy, the dermal LIC can be achieved through the direct dermal injury. So we propose a so-called dual plane of cavitation from dual wavelengths of fractional pico handpiece. So we apply the 532 fractional pico to try to create maximal LLB in the epidermis, and followed by tensor 4 fractional pico because we already use the melanin in the epidermis. So the tensor 4 fractional pico energy can go straight down to the dermis to create LIC. So we end up to get LIOB and LIC at the same time. So look at the histology, shows the same concept. Look at the LIC, the breakdown here in the dermis. Can you see the breakdown in the dermis just beneath the breakdown in the epidermis? So we create the epidermal cavitation first, then we fire the tensor go straight down just beneath the area of epidermal LIOB, then we can create LIC. Otherwise, sometimes it's not very easy to predict to create LIC at certain energy ranges. So PicoWay has 4 versatile wavelengths, 730, 785, 532, tensor 4, and they all have very high energy and peak power with very short pulse duration range from 250 to 450 picosecond. And the unique technique of holograph beam splinter is also very useful to deliver the energy from the handpiece to the surface of the skin without any energy loss compared to the micro lens array. So now the current approved application for the PicoWay include the tattoo removal, pigment removal, rejuvenation, acne scar removal, wrinkle removal. But I want to mention about some future applications such as vessel removal, acne improvement, or transepidermal drug delivery for PicoWay lasers. So the success to treat the tattoo with lasers can be determined by several factors, such as tattoo colors, wavelengths, spot size, and pulse duration. And sometimes the adjunctive therapy need to be combined, such as fractional laser and R20. So here you can see different color was responding to different wavelengths. And here you can see with a combination of 532, 730, 785, and tensor 4, we can treat the whole spectrum of color tattoo from red, orange, yellow, green, blue, purple to black. So black color is very easy to be treated with either 730, 785, and tensor 4. Here you can see several treatment. And here you can see the blue color was responsive to 785 nanometer. Red color was responsive to 532 nanometer. So sometimes for very dense and huge tattoo, the combination of a picosecond laser and fractional laser is needed. So here you can see very multi-color tattoo removal with 532 for red and yellow color, and 785 for blue and green colors, and 1064 for black colors. You can see red color 532, blue color 785. In other cases, with a combination of pico and fractional CO2, here you can see 1 month after one treatment, the results quite nice. Full treatment with a combination, you can see the result. See 1 month. So blue color is quite responsive to 730 nanometer, 2 months. It's before and after. It's done. Green color, 730. So this case has been treated with nanosecond lasers with scarring and without further improvement at last two treatment. So even though we still treat the cases with a combination of pico and fractional CO2, you can see 1 month after two treatment, we still have continuous improvement. So R20 enhancement method is also useful for especially fresh tattoo. So this is a fresh tattoo. The patient had come to me just 1 month immediately after the tattooing. So we at the very beginning we treat the patient with a combination of 755 pico and fractional CO2. But here you can see after 3 treatment, the result is not significant. But later, when we use R20 method, you can see 3 treatment, the result is quite nice. So R20 method is quite useful for the so-called fresh tattooing. So PicoWay is useful to treat the Asian photo aging signs. So most of the patients come to me want to remove their wrinkle and dark circle under the eye, the dark spot pigmentations on the lower to mid to lower faces, and pore, large pore in central faces. So enlarged pore is related to the aging process of dermopapilla. I want to mention about dermopapilla because dermopapilla is not only the bridge between the epidermis and dermis, it was also the only dermal area to consist predominant type 3 collagen. So when we are agents, it becomes flattened and shortened. So so it loses pore to refine the pore size. So we get the enlarged pore when we are agents. In this article, they compare 4 devices, 1 nanosecond and 3 millisecond, and they conclude the full thermal created by the millisecond device can produce more type 1 collagens, and the photomechanical effect created by the nanosecond lasers can produce more type 3 collagens. So that means if we can apply a shorter pulse duration, we can induce more type 3 collagen. Then we can remodel the dermopapilla, and we can improve the enlarged pore. So what I always treat the acne scar and pore with a combination of 532 and 1064 fraction pico. I try to induce not only epidermal LLV, but the direct dermal LIC at the same time, as I mentioned the technique before. So we use the dual planes cavitation technique to treat the acne scar and pore size. So you can see there are some improvement with the combination of 532 and 1064 fractional. Here you can see there are some improvement at full treatment. And for this lady, you can see she was not only improved in the acne scar and pore, but also the acne itself 2 months after 3 treatment. Here you can see 2 months after 3 treatment, the patient was improved not only the acne scar, but also acne. I will talk about the mechanism of the improvement of acne later. So this is another case. You can see the improvement of acne scar and acne itself. So in this article, they compare the started changes of 755, 532, and 1064 nanometer fractional pico. And here you can see with 755, there's only epidermal vacuoles without dermal changes. However, no matter with 532 or 1064 fractional pico, we can not only see the vacuole in epidermis, we can also see some disruption, extravasations in the papillodermis. So it means there are some insult of the papillodermis vascular structures. So the reason is because 755 has a higher melanin and hemoglobin absorption ratios. Here you can see. But is this advantage or disadvantage? We don't understand. Here you can see the melasma usually accompanied by the vascular structures here. And not only melasma, the soil lentigo was also proved to have increase of blood vessel structures. And hemangioma have some overlying increase of melanin. So we don't know the consequence of melanin and vascular structures. But in this article, they conclude that endothelial cells in the dermis can increase the melanogenesis pathway in melanocytes. So in this retrospective analytical study, they use pulse dye in combination with fractional low power diode lasers. And the result shows the more improvement of erythema, the more improvement of melasma. So there are some relationship between the melasma and erythema. So at the very beginning, we use 1064 fractional pico to treat the vascular malformation here. But as you can see, after a couple months, you can see there's some improvement on the side of 1064 fractional pico. So this case was anecdotal cases because at the very beginning we just try to treat the melasma and the process on the central face areas. So we use the combination of 532 and 1064 fractional pico on the central faces, but it ended up to improve not only melasma but also the erythema on the nose. So you can see there are some improvement in the melasma areas and also the erythema areas. So this is another case with dyschromia with erythema, but after several treatment of the combination of 532 and 1064 fractional pico, you can see there's some improvement of the erythema and the nose. This is another case. You can see there's some improvement of melasma and erythema. So in terms of the pigmentation treatment, at the very beginning, we think can we induce more high photomechanical effect in the treatment of pigmentation lesions. However, when you pick up one device, the particle size is fixed, the wavelength is fixed, the path width is all fixed. The only thing we can do is to adjust the fluence to induce more high photomechanical effect. So how can we do that? As you know, the tissue damage ranges as a function of energies. So when the energy is exceeding the plasma formation, if it continues to give high energy, more cavitation was induced. If it continue to give a low energies, more shockwave injury was induced. So what's the difference between the shockwave and cavitations? And in cavitation, you usually produce more significant injuries, such as photo disruption and photomechanical impact. However, in shockwave, the injury was usually subtle, such as subcellular and functional injury. So in the treatment of the pigmentation, we want to induce more shockwave injury instead of the cavitation injury. So at the very beginning, we treat the epidermal pigmentation and set the endpoint of nanosecond. We use 532 joule and at endpoint of frosting whitening. And look at the histology, it shows striking ballooning cell and cavitation in the epidermis. So that means the thermal impact was still high. But some doctors says if we can decrease the energy a little bit and set the endpoint at grayish discoloration. So we set this patient at the endpoint of grayish discoloration, and we see, you can see the histology change is quite similar to the previous one, but not as striking as previous one in terms of balloon cell. But however, look at the junction, look at the base membrane. The injury was still there. That means the risk of pH was still remaining, even we set the endpoint at the grayish discolorations. So we try to induce a low energy to apply low energy to induce more photomechanical effects. So this is our first case. So one side was treated with 532, the other side was treated with TensorFlow with different energies. And you can see after 1 day, it shows crossing on both areas. That means the energy was still very high. So in terms of photomechanical effect, this is the only article that compare the low energy and high energies. They conclude for low energy, half energy need at least a 3-step sharp pulses to achieve similar tissue damage. So we still need to lower the energy to certain level. So in this case, you can see there are significant lentigo here. We use low energy, several overlaying passes. You can see on day 2, there's no crossing at all. However, on day 28, you can see there are no pigmentations at all. The pigmentation was totally removed. So we prove the pigmentation was removed predominantly by the photomechanical effect instead of photothermal. This is another side you can see here, no crossing, but 28 days you can see the pigmentation was improved. It's another case you can see the lentigo here on day 2 days, no significant crossing. However, on day 28 you can see the pigmentation was almost removed. So we treat this patient one side with high energy, the other side was treated with low energy, multiple passes you can see on day 2. Here shows some crossing. There's no crossing here at all. And here you can see 2 months after two treatment, you can see the pigmentation was removed quite well. However, on the other side, on the side with low fluence, the pigmentation was also quite clear. This is another case you can see one side was treated high energy. It shows crossing on day 2, and there's no crossing on the side of low fluence. However, 2 months after, you can see the result is quite similar. But the big difference is patient doesn't need to experience any downtime in terms of crossing, erosion, or pH. So this is another case you can see on day 3, crossing, no crossing. 1 month after one treatment, you can see the result is similar. So we can use the same technique with a 785 picosecond nanometer pulses. You can see with multiple pulses, we can treat and remove the pigmentation after pre-treatment quite well. You can see here the removal is quite nice. So what's the difference between photothermal and photomechanical? In photothermal, the histology usually shows significant changes such as hyalinization or collagen and vascularization intracellular and extracellular. However, in photomechanical effect, The change is usually subtle, such as marginalization of nucleus and vacuolization of the cells. So this slide article shows the difference between the full mechanical effect done by nanosecond Nd:YAG laser and full thermal effect done by ruby laser. Here you can see there's no significant changes. However, in ruby laser's full thermal effect, it shows striking necrosis of the cells. So what's the historical change of our cases? We use 532, very low energy, multiple passes. You can see it shows intracellular vacuole, clear cell, all along the epidermis. So it's a intracellular LIOB. So when we apply the low fluence, but too many passes still can induce ballooning cells again. Here you can see, so that means the injury was still too high. So we also done electron microscope. You can see we use 532 standard, very low fluence. You can see there are some disruption of myelin pieces here, and you can see, but no significant disruption of adjacent tissues. And even we use 532 fractional picos, and you can see there are also some disruption of myelin, but no significant adjacent tissue disruption. So how do I treat the mid-phase photoaging rejuvenations? I usually combination of standard and fractional pico and try to apply the high photomechanical effect technique and dual plane cavitation technique. So here you can see the conventional photoaging skin, and the pigmentation was treated with the 785 in combination 532 and 1064. And here you can see the result. And here you can see the removal of pigmentation and rejuvenation of the skin. The removal of the lentigo and the rejuvenation of the skin. So can we treat the dermomelanosis with the so-called high photomechanical effect? So the answer is yes. This is very early cases. We treat the nevus zygomaticus with a high fluence, single passes with combination of 530 to 1064, and set endpoint just nanosecond. So we use 532 to see the frosting changes, and followed by 1064 nanometer with several passes. But you can see the patient still suffering PIH for 6 months. So even we apply the picosecond laser, we still have PIH. So later, when the patient PIH go away, we treat the patients with combination of 532 and 1064 with very low fluence. And you can see the result is quite nice. 1 month after 2 treatment with a 6 weeks interval. But the big difference is patient doesn't need to experience any downtime in terms of erosion, crusting, hemorrhage, and PIH this time. So we treat the nevus zygomaticus with 532 and 1064, so-called high photomechanical effect technique. You can see without any significant downtime. So melasma is most difficult to be treated with energy-based devices. It can be influenced by not only keratinocyte fibroblasts, but also endothelial cell and sepocytes. And recently, the post-laser treatment regimen is quite important, especially within 2 weeks post-treatment. So I usually apply 730 nanometer or 532 1064 alone, or both 730 and 1064 standard handpiece, and followed by 532 or 1064 fractional pico. So these very early cases are treated with 532 and 1064. You can see 2 months after treatment, the result is nice. This is a case with a PIH done elsewhere with unknown devices for stable for 6 months. But even though we treat this patient with a combination of 530 for 3 months after full treatment. The result is nice. The result is nice. This is a non-virgin melasma case, was treated with 530 intensive for low fluence. You can see 4 months after free treatment, the result is nice. This patient was treated with 785 in combination with 1064 fractional. Some improvement, 785 in combination 530 intensive 4 fractional. For treatment, 785 in combination 530 intensive 4, 532. So 730 nanometer handpiece is just launched in the market, and it has the shortest pulse duration of 250 picosecond and highest peak power of 0.4 gigawatts. With a combination of shortest pulse duration and the highest peak power, we can induce the maximum photoacoustic effect without too much thermal effect, and that's a decrease of the risk of PIH. Here you can see the melanocyte absorption is between 532 and 1064. However, the melanin hemoglobin ratio is highest compared to 755 or 1064 and 785. And also blue color and green color was quite responsive to 730 nanometer. So with the shortest pulse duration of 730, we can induce high photomechanical effect in the treatment of pigmentations. This is specifications when we compare 785 and 730. It has a better advantage specification compared to 785. So we just wonder, when we apply such a shortest pulse duration in the melasma skin, what happened beneath the skin? So we down the biopsy here, you can see we use high energy 1.8, the maximum high energy 1.8 with a 3 millimeter in the melasma skin. You can see it shows striking ballooning cells in the epidermis. And on the other side, we treat the melasma lesions with the lowest energy 1.1 joule per centimeter square with 3 overlapping shots. You can see it also shows very full blown of ballooning cells. Now, at high magnification, you can see some difference. You can see there are some disorientations of the keratinocytes and also some ballooning and spongiosis between the cell. And also you can see the junction. There are some vacuole in the junction, some disruption of the junction with high energy. However, with low energy settings with overlapping shots, you can see the junction is more intact compared to the high energy, and the keratinous ballooning keratinocytes were more arranged normally. So 730 here, you can see the result is nice. You can see some pigmentation can be easy to be treated with 730. The shortest pulse durations, you can see the result is quite nice. 1 month after two treatment, 1 month after 2 treatment without PIH. You can see here the photoagent melasma cases. You can see the pigmentation can be removed quite well in combination with 532 fractional pico. Here you can see the improvement is quite nice. You can see the lentigo and dyschromia can be improved 2 months after 1 month. This is another case. You can see photoagent and can be improved after 2 treatment. You can see there are so much improvement here, and also skin textures. So this is an algorithm of what we've done for pigmentations with 730 and 530 1064 nanometers. And for epidermal lesions, it can be treated with either high photothermal or high photomechanical effect technique. For dermal pigmentation, it had to be better to treat with high photomechanical effect. For melasma cases, only high photomechanical technique was recommended. 2 years ago, we also used 532 fractional pico to treat the pig skin to see if there any increase of in transepidermal drug delivery. And we use FITC and hydroquinone as a transepidermal drug. And the result shows there's a significant increase in hands of the transepidermal drug delivery in no matter in FITC or hydroquinone. Here you can see. So we use fractional 532 pico energy to create expanding extracellular space of strong cornea by photomechanical wave and LLV cavitation. Thus, it will enhance the drug delivery through the strong cornea and epidermis. In this article, they use tranexamic acid to reduce the laser-induced melanogenesis. So we try to use topical tranexamic acid to reduce the pH rate. So the mechanism has been already proved from the Wellman lab since 2010. So this article that shows how photomechanical wave can enhance transepidermal drug delivery. You can see there are some increase of fluorescent materials here in the dermis. This article shows similar results, but they didn't see the histology changes to prove the mechanism of enhance of the transepidermal drug delivery. Only under the electron microscope they can find the increase of the expanded lacuna domain within the intercellular lamella of the strong cornea. So it's very ultra structurous finding. However, in our cases, in our histology, you can see there's obvious vacuoles intra strong cornea and substrate cornea to disrupt the strong cornea intake. Thus, we can enhance the transepidermal drug delivery. Also, the cavitation in the epidermis, and also here we can find the cavitation in the follicular epithelium. So with the cavitation in the strong cornea, under strong cornea, in the epidermis, and in the follicular epithelium, those are attributed to the enhancement of transepidermal drug delivery. And this finding also can prove the improvement of the acne because it will induce some keratinizations of follicular epithelium. Thus, maybe we can improve the acne formations. So we also done some OCT image here. You can see 532. There are some uniform tiny cavitation in the epidermis. Here shows 1064 larger cavitations. So the application of drug is also, the timing for application is also critical. In this study, they use OCT to demonstrate the channel of the opening of the breakdown, and the result shows within 30 minutes the channel will 100% open. However, at 6 hours, only 75% of the channel are open. So this is our scenario. Shockwave pressures can expand lacuna domain pathway of strong corneas, and also cavitations and vacuoles in strong cornea epidermis and follicular epithelium can also facilitate transepidermal drug delivery. So we started to treat the patients with standard handpiece in combination with 532 fractional to try to enhance transepidermal drug delivery mechanism with the topical tranexamic acid application. Here you can see after 2 treatment, the result is nice without pH. Here you can see for Nimbus zygomaticus, even we use high energy full treatment, we didn't see pH. So we apply topical and tranexamic acid immediately after the treatment. Here, the patient was treated with 730 in combination with 532 fraction pico, and we also apply tranexamic acid immediately after treatment and within 2 days. Here you can see 2 months after 2 treatment, 2 months after 1 treatment, 730, very gentle removal of the pigmentation in combination with 532. So, in conclusion, treating Asian pigmentation with no matter 532, 730, 785, 1064 is safe and effective. However, optimal photomechanical impact made by optimal energy setting different from the endpoint of Q3 nanosecond can be reduced the complication of pigmentation alterations. And LIOB with different energy setting can induce at different tissue levels. And melasma is most challenging to be treated with energy-based devices. But now we can see more consistent result from the picosecond laser because it can be achieved through the 3 key mechanisms of less thermal melanin disruption with shortest pathways with of 730 and thermal neocollagenesis and activating melanogenesis with inhibitor delivery with golden hours after laser treatment. And we think the picosecond laser drug delivery may potentially enhance the future efficacy in more indications such as pigmentation treatment and collagen production treatment and rejuvenation in the near future. So thank you for your attention.
Thank you very much, Dr. Carr, for the wonderful and in-depth sharing. We have received some questions from the audience, and the first one is that as the traditional Q-switch NDX toning for melasma was widely used, and some physicians believe combining it with short-duration picosecond laser will achieve further improvement, what is your view on that?
Yeah, as we mentioned, because nanosecond and picosecond can all induce photomechanical effects, but the problem is what is the optimal energy settings for the treatment of melasma. But so far, because if we can use shortest path duration to disrupt the melanin with very confined injury of the melanin containing keratinocytes, we can reduce the incidence of PIH. So if we can apply the shortest picosecond lasers in the treatment of melasma in combinations of post-laser drug delivery, I think for me is a better way to ensure we can have continuous improvement without significant PIH insult.
Okay, thank you. And also the second question is, as the market is actively promoting the advantages of short pulse duration picosecond laser, do you still see the needs to have a nanosecond laser in the clinic?
Another picosecond.
So because the market is promoting a lot on the short pulse duration picosecond laser, and the audience asks whether do you still see the needs to have a nanosecond laser in the clinic?
Yeah, it depends what kind of indication you need to treat mostly in your practice. If you don't want to treat the melasma case, it's a very sensitive skin, and usually nanosecond can induce more strong photomechanical actions in the treatment of in terms of the rejuvenation or wrinkle removal. So nanosecond is still needed if you have a whole bunch of patients needed, such as senile lentigo, seborrheic keratosis. I think nanosecond laser will be more useful for the picosecond. On the other hand, when your patients were all melasma patients or those very unstable pigmented lesions, I would say picosecond is much better than nanosecond laser.
Thank you. And the third question is, would you think the 730 nanometers handpiece works better generally again compared to the 785 or 755 nanometers on the treatment efficacy for different benign pigment lesions? And well, because I covered melasma, but yeah, just a bit more elaboration in terms of your views on that.
Yeah, it is also based on what kind of indication you try to treat. So because I show you the histology changes when I apply 730 with high energy and low energy, and the histology show me some fact is 730 can really induce very precise photomechanical effect and very confined injury in the tissues. So I think again, if you try to treat the melasma case, very unstable pigmentation, photoaging skin, 730 will be the most promising wavelengths, I think. But the problem is, what is the optimal endpoint of your energy setting and clinical finding? So I'm still looking for the endpoint. But so far, I treat a lot of patients. I see the pH rate is still really low. So I do believe we may need to use such a shortest postulation to induce precise cell injury to reduce the aggressive injury of junction area and subsequent to reduce the pH rate.
Thank you. And also, did you use any vascular laser in reducing the vascular melasma as shown earlier? And how does PicoWay laser actually targets the hemoglobin and also in one of your sharing?
Yeah, I try. I'm probably not very experienced in that, but I've been trying to use no matter long pulse, tensor flow, or pulse dye, or IPL in combination with picosecond lasers or nanosecond laser in the treatment of melasma. But I think the result is quite variable, not really consistent. So far, I was more conservative when I encounter the patients with combination of vascular structures and pigmented melasmas. I try to use only picosecond laser to treat the pigmentations and also remove very small part of vessels from picosecond lasers.
I see. Thank you. And the next question is, how would you determine which type of clinical endpoints that you're going after? For example, like more whitening or just mild frosting? Is that depending on the types of pigmented lesion? And if so, like how would you really determine it?
Yeah, so in my experience, if you try to apply so-called high photomechanical effect, you don't need to induce even a little frosting or whitening. The only thing you have to induce is striking erythema. I mean, if you try to just copy my way to induce a high photomechanical effect without significant photothermal effect, the endpoint is striking erythema. However, if you try to use the conventional photothermal effect in treating such as epidermal pigmentations, the whitening or frosting will depend on which wavelength and which pulse duration you use. For example, so far, if I treat the 730, I think I need to induce quite significant whitening, then I can really remove the freckle or simple lentigo. However, if I apply 532, I don't need to induce such a significant whitening or frosting, then I can remove the pigmentation. So based on different type of web lens and based on different postulation, so you can determine what kind of frosting or whitening you have to achieve.
Thank you, Dr. Carl. Just one last question, because there have been a lot of wonderful cases of treating melasma, and the audience would wonder, like, if we look at starting to plan a treatment for melasma, what would be your suggestion in terms of planning the treatment for the melasma? Like, for example, not diagnosing the melasma, and also how to approach it as the plan.
Okay, so far, I would say, because the energy device cannot provide always very consistent results, as you know. So yeah, for me, it's still the energy base is still for me is the second line. So for most of the patient, if I can try topical first, I will try topical first, and then if it doesn't work, or the patient was very anxious and eager to have laser treatment, I will treat starting from very short pulse durations wavelengths with very low frequency to try to remove very superficial to mid-level of epidermis to remove of the melanin-containing keratinocyte to metabolize those pigmentation in the epidermis. Then I will go further at the second session or third sections with higher energy to remove. As I show you previously with the 730 with 1.1 energies with 3 overlapping pulses, you can see there's no injury of the junction. So I do believe we can use very shortest pulse durations of the web lens. It will be more confident or more safe to remove the pigmentation. And my goal will be remove part of the melanin in the epidermis, and at the same time I will apply the fractional 532 to try to disrupt the skin the skin, and to try to enhance topical agent. So I try to remove part of the melanin in the epidermis and enhance the topical melanin inhibitor to get the combination result of the melanin, especially melasma. I'm sorry.
Sure, thank you. And so, once again, our sincere appreciation for Dr. Carl's time in sharing such great information and clinical experiences. And surely we have all gained new knowledge. And also thank you everyone for joining us today. We hope this webinar is rewarding for you, and we look forward in seeing you next time. Thank you, Dr. Carl. Thank you, everyone.
Thank you.